Hello, friends, and welcome back to Dr. A. Sajid. As promised on the Instagram channel, today we'll be talking about plantar fasciitis. Let's choose our colors. Sorry. So we'll be talking about plantar fasciitis today. As a trainee here in the Northeast, I tend to see this a lot in the GP setting, and I thought perhaps we can talk about it and see if we can help our patients by making quicker diagnosis and treating them and referring them in the right way possible. Now, when we talk about the NICE guidelines divides plantar fasciitis into various parts, and we'll go forwards dividing it off as well as we skim through the NICE guidelines. The first part where the guidelines talk about the definition. Now, I understand that there's this fasciitis eventually at the end of the name, and it should refer to chronic inflammation, but it's a misnomer and it's chronic degeneration of the fascia, and that eventually leads to persistent heel pain. And you'll have the typical patient in the GP setting where the patient will come in and say that, oh, doctor, I've got this heel pain. And we'll talk about the characteristics. And it's very easy to diagnose at the end of the day in a GP setting. And whilst one would just simply want to give painkillers or physiotherapy without really knowing what it is, it would be good to know exactly where the musculoskeletal pain is coming from and how we can educate our patients if we know the diagnosis ourselves, because we can put them forwards for leaflets, and the leaflets can help manage their symptoms a lot more given that they're aware with what's wrong with them as well. So it's the definition beginning off is very simple: chronic degeneration of the fascia leading to persistent heel pain. Next up, it talks about the causes, and the NICE guidelines talks about the general causes, but we'll divide it off into two: the intrinsic causes and the extrinsic causes. Now, when we talk about the intrinsic causes, they would be the typical ones, which basically means any deformity of, and that would actually say previous deformity of the foot. So this would basically mean high arch or excessive or overpronation of the foot. Or we can have a leg length disparity, which is basically if you've got two unequal legs, then that would be something to look into. And then we can have the intrinsic factors. The intrinsic factors is what you'd see much in the GP setting, because if somebody's got a high arch, they'll already be under orthopedics, and that patient would have the diagnosis of plantar fasciitis via the specialist. And it's very unlikely that somebody with a chronic condition will come to the GP setting for heel pain, given that they'll have the orthopedics at the back of their hand. But it's always good to know if somebody's got a deformity of the foot and or a congenital thing, or they've got a long extensive orthopedic history, we can definitely give plantar fasciitis a bigger thought than the other differential diagnoses. But these extrinsic ones are where the patient will mainly present with. So this would be a patient who would say, oh, I've got this heel pain, and doctor, I've got a young toddler and I was playing hide and seek and I think I splinted my ankle then. So that's like a history of trauma eventually. Or they can talk about how they've bought these new shoes that don't really feel well with the foot. So overuse is one of the extrinsic causes. We've got inappropriate footwear, trauma, and any mechanical stress are the typical causes of plantar fasciitis that you would notice in a GP setting. After the causes, the third thing that the NICE guideline talks about is the diagnosis. Now, this is a very, very clinical diagnosis, and it would be divided off into very clear branches. Let's not make a tree over here. Let's give ourselves some space because we've got the other half of the blackboard free. Let's see what will we depend our diagnosis on. We'll depend it on the history and the examination. Now, when we talk about the history, the patient will give us the presenting complaint, and that very well will be the heel pain. But whilst we're talking to them, we'd want to think about other stuff. So in the history, we want to focus our we want to focus ourselves on two things. If it's heel pain, then what kind of pain is it? The typical plantar fasciitis patient would say that, oh, doctor, I've got this heel pain that gets worse in the morning. So the first few steps, worse after inactivity is the right way to put it. So the first few steps in the morning are the worst. Or if I've been sitting for a long time and I suddenly start walking, the heel pain that comes after those initial first two steps are excruciating. So that would be a very typical presenting complaint from the patient. Next up, they can talk about how they thought that the pain was coming from the heel, so now they've been walking on the tiptoes, and that makes the pain worse. So tiptoe walking makes this worse. And then they can also talk about how sitting with the foot elevated makes it better. So what makes it better would be elevated foot. And lastly, this is also again very, very typical for plantar fasciitis. So the patient would say that, oh doctor, when I'm sleeping, the pain's not there. When I wake up in the morning and I take the first few steps, the pain is excruciating. Then I go on with my day, things start to get okay. But then when I hit the gym and I do exercise, that's when the pain comes out again. So initial activity brings out pain. Moderate activity doesn't bring out pain, but excessive overuse brings the pain again. So severe or extensive exercise makes the pain worse. So let's clear it out a little bit more. Heel pain that's worse after inactivity, so early morning. Patient will try to walk on the tiptoe, and walking on the toes will make the pain worse. Elevating the foot makes the pain better, and excessive or severe extensive exercise makes the pain worse again. The other stuff that you'd be curious about is there any trauma? You'll talk about the footwear. When was it last changed, and how is it? Is it good? Is it a good quality footwear? And another thing that you'd want to look into is sports. So do they play any sports? Do they play badminton? Do they go to the gym? And we will take it forwards from there. So that's pretty much the history, and the history itself will give you the diagnosis. If we're a bit confused with the history, or if we've got the diagnosis and we'd want the examination to put forwards the answer, or to confirm the diagnosis for ourselves, then this is where we want to go forwards to. When we do the examination, because like I've mentioned that the history itself would be very particular for plantar fasciitis. However, we'd want to either rule it in or we'd want to rule it out. So if you want to rule in plantar fasciitis, there would be a few things, and you'd be like, you know what, I've got the diagnosis and this is it. But then you'd still want to rule out a few things just to be careful that you're not missing out anything else. One physical exam that would confirm your diagnosis would be to 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 palpate it in general. So if you were to face any tenderness over the medial calcanean tuberosity, that will confirm your diagnosis. Let's keep it a little bit out. I'll just delete it off like that. Okay. So if you have tenderness over the medial calcanean tuberosity, that rules in your plantar fasciitis. This is very important because most of the times when you have the patient and you tell the patient to take off their socks, they will, if they've got plantar fasciitis, they'll simply just put the finger on the medial calcanean tuberosity. And the reason behind that is that the plantar fascia starts from the medial calcanean tuberosity. It goes around and under the plantar surface of the foot, so the heel itself, and it gets attached to the base of the toes. So it would be very typical for patients to simply just say, oh, I've got pain at the medial calcanean tuberosity, because that's, and they'll be holding that then and there, and you'd know that this is plantar fasciitis at the end of the day. In addition to that, because the same fascia goes from the medial calcanean tuberosity and it's inserted at the base of the toes, if we produce toe dorsiflexion, that will mimic the pain as well. So we've got two very simple tests to simply get ourselves down to the right diagnosis. Tenderness over the medial calcanean tuberosity and toe dorsiflexion will mimic the pain. What else can we do to rule it in? That's pretty much. The NICE guideline also explains that toe dorsiflexion is quite similar to standing on your toes. Which is why if we link it up to the history, the heel pain was getting worse on standing on the toes. So that's another point to pick up. Next up would be things that rule out plantar fasciitis. And this is a long list. I'm just going to take a picture of the iPad here so that we've got a thumbnail for the YouTube video, and then we'll erase much of the screen and we'll make it clear again and then talk about the rule out stuff. Let's take a picture and we'll just save it out to photos. Okay, now in order to rule out, let's start by over here. We've got the Achilles tendinitis that we'd want to rule out, number one. Now Achilles tendinitis tends to have pain at the back of the heel, and if we're able to palpate the back of the heel and the tendon itself, we should be able to rule it out. Number two would be subcalcanean bursitis. Now this would present as a swelling under the calcaneum, and because again it would be hard to tell if it because the patient would be touching the medial calcanean tuberosity, it would be hard to tell the bursitis from the plantar fasciitis. But we have to remember that the fascia itself is starting and originating from the medial calcanean tuberosity, and it's going and attaching itself to the base of the toes, And if we dorsiflex the toes, the pain shouldn't come about in the subcalcanean bursitis because the bursa is very local to the calcaneum bone itself. So that's number 2. Number 3 would be a radiculopathy, which is S1 or S2 radiculopathy. This we should be able to quite easily differentiate because we'll have other symptoms of nerve entrapment, like numbness would be there, and also the straight leg raise test would be positive in this. So straight leg raise test would be positive, and along with you'd have an absent ankle reflex. So that's number 3. Number 4 for us would be a fracture of the calcaneum. And the way to differentiate it is that there would be tenderness over the bone rather than anterior to it, because the origin of the muscle is anterior, from the anterior aspect of the bone. So this would be fairly based on examination and experience at the end of the day. Number 5 would be Morton's neuroma, and this was pretty interesting for me because we've actually diagnosed Morton's neuroma with my clinical supervisor whilst I was working here. The pain tends to come about between the heads of the second and the third metatarsal, or the third and the fourth metatarsal. So though it would be very different from the heel pain, but if you palpate the space in between the second and the third metatarsal and the space in between the third and the fourth metatarsal, and then there's pain there on examination, you'd want to think more than plantar fasciitis and more into the Morton's neuroma. And lastly would be the tarsal tunnel syndrome. Now I'll be very honest about this one. I've had so many patients. In fact, there was just a man a few weeks ago that I saw, and he was complaining about burning and numbness just on the medial aspect of the foot. And to be honest, at that point, I did not know what he was talking about. But now that I've read through the guidelines, it could possibly be the tarsal tunnel syndrome. And like we've talked about in this channel, we learn together. So perhaps we can do the next video on the tarsal tunnel syndrome, and we can be a bit more confident diagnosing our patients with that at the end of the day. So this was a little bit lengthy, I assume. The ruling out bit. Ruling in is very easy. Patient would be holding the calcanean, medial calcanean tuberosity and saying this is where the pain comes from. And second bit, the patient will also talk about how getting on the tiptoes, the pain gets worse. So if you were to dorsiflex the toes at the end of the day, the pain should be worse and it should mimic the original pain. The ruling out bit, I understand it's a bit complicated, but we've tried to keep it very simple. We've got 6 things to rule out. We've got the Achilles tendonitis. We'll palpate the tendon itself. Hopefully that should be okay and that should rule out the disorder. We can have the subcalcanean bursitis. Now the subcalcanean bursitis would be very localized. The pain would be something very similar to the patient touching the medial calcanean tuberosity, but the dorsiflexion shouldn't bring out that pain because the fascia isn't inflamed, and the fascia is the one that gets attached to the base of the toes. It could be radiculopathy, but for the radiculopathy, we should have the straight leg raise test that should be positive with the back pain and an absent ankle reflex. We could also have a fracture. The fracture itself would be very localized and there should be swelling or a history of trauma as well. Lastly, we can have Morton's neuroma. For the Morton's neuroma, the pain would be between second and third metatarsal and between third and fourth metatarsal, because that's where the common digital nerve passes through, and it would be more of that disorder. And lastly is the tarsal tunnel syndrome, which presents as burning and numbness and pain on the medial aspect of the foot. We'll look more into it. I'll make another video about it and perhaps we can learn together about it. So, in short, when we rule out, we've also done the differential diagnosis of plantar fasciitis. Let me just let me just erase this blackboard, and then we can go forwards and talk about the treatment options. Let's erase it off from this end a little bit. We don't need a lot of space. Hopefully, we should be okay. Almost there. Sorry, guys. Right. Done. Now, just to recap, I know it's written on the other end of the board, but just to recap, we've done the differential diagnosis as well. So we've got Achilles tendonitis, we've got subcalcanean bursitis, we've got a fracture, we've got Morton's neuroma, and we've got radiculopathy, and we've got tarsal tunnel syndrome. Now, let's look into the treatment options that NICE guidelines presents us with. And they've divided it off into self-care, into meds, physiotherapy, corticosteroid injections, and lastly would be orthoreferral. Now, self-care would be to reduce weight, shoes, to concentrate on the best kind of shoes, rest. For meds, we've got paracetamol and NSAIDs. Physiotherapy, it could be via the physiotherapist or it could be self-physiotherapy. And if you want to see how they want to talk about this self-physiotherapy, the last page of the NICE guidelines demonstrates the exact exercises that they can do at home. Corticosteroid injections, they've talked about how it shows a short-term benefit but nothing in the long term. And orthopedics referral. Now, when would we refer to orthopedics is if we'd want the patient to go for more than just conservative managements, but for something known as the extracorporeal shock therapy or surgery. So just to repeat, self-care with loss of weight, shoes and rest. We've got meds with paracetamol and NSAIDs being the top winners. Physiotherapy at home, self or from any place that with the specialist itself. Corticosteroid injections for anybody who wants short-term benefit, and then orthopedics referral for shockwave therapy or something more than conservative managements like surgery. So this is my take on plantar fasciitis. As a GP, I'll be honest, I tend to concentrate more on counseling regarding the self-care, on meds and physiotherapy. For recurrent plantar fasciitis, as per the NICE guidelines, 80% of the patients get better in 12 months. So talking about the prognosis with the patients is very important. And most of the patients understand that the prognosis will come about, but you'll always have a few who will pop back in with the same complaints, and that's where you can bring in either the orthopedics referral to take the specialist into care of the patient as well, or corticosteroids with just short-term benefit, which now I assume is not covered by the NHS. So that's my take on the plantar fasciitis. It was fun reading with you guys. I've got exams coming forwards as well, so it's always good to have a partner to read with, to go over things with. So thank you for watching. It's Dr. A Sajid on YouTube. Don't forget to comment, like, and subscribe. Have a nice day, guys. Bye.